Thank you for coming. This is the workshop on rectal cancer MRI post-treatment evaluation. I'll start us off by talking about rectal cancer restaging after chemoradiation, and then Katrina McGinty from UNC will talk about imaging of rectal cancer recurrence. I have no financial disclosures. So the outline for my talk, we'll discuss briefly rectal cancer management and why it's important to restage rectal cancer after chemoradiation with MRI. I'll mention again the rectal MRI protocol. Some of this will overlap with the lecture I gave this morning on initial staging of rectal cancer with MRI. And then we'll discuss the findings specifically in the post-chemoradiation setting. And then we'll have a specific sample report template. Just as a reminder, initial staging on MRI of rectal cancer is based on the involvement of the layers of the rectal wall. So a T1 tumor involves the mucosa and submucosa. A T2 involves the muscularis propria but does not extend past the muscularis propria into the mesorectal fat. T3 extends outside the muscularis propria into the mesorectal fat. And then T4 involves either the visceral peritoneum or adjacent organs or both. So this is kind of where we draw the line, the T2 versus T3. T2 and T1 tumors go straight to resection, while most T3 and above get chemoradiation prior to resection. And then these are the locally advanced cancers that get restaged with MRI after chemoradiation to assess for tumor response. And this gives us information about prognosis, surgical planning, and in some cases can also result in non-operative management. So let's talk about that briefly. So this morning I talked about how the management of rectal cancer is resection with or without chemoradiation. Well, in a subset of patients, and this is particularly in Europe where this is standard of care, in certain patients that achieve complete response, these patients can be managed with surveillance and what they call a watch and wait approach. Now in the US, this is not standard of care per NCCN guidelines, but is still adopted in certain patients who may be poor surgical candidates or may not want an ostomy, for example. So the data on this is mostly from Europe, and this is just 4 of the studies that I have listed here. It's a busy table. What I want you to focus on is all studies compare disease-free survival and overall survival, looking at patients that underwent the watchful wait versus the resection. And most of these did not show any significant difference. The ones that actually were significant, the watchful wait approach actually had higher disease-free and overall survival. So these patients can, at least based on these data, safely be followed. And now it has to be a subset of patients with complete response after chemoradiation, which is achieved in up to 35% of patients, depending on which author you read. And the assessment for complete response is done clinically as well as with MRI. And MRI really plays an important role in the setting and has moderate sensitivity and high specificity in detecting complete response. So again, the rectal MRI protocol, it's very similar to the pre-radiation imaging protocol. We start with the sagittal and axial T2 weighted images. We identify the tumor here on the sagittal weighted images, and then we draw a cross-section through the tumor, which is the plane for the axial oblique imaging, like so. And then a plane that's parallel to the length of the tumor, that would be your coronal oblique plane. And then really important, especially in the post-chemoradiation setting, is the diffusion-weighted imaging. And the pre- and post-contrast T1 weighted images are, again, optional, not necessarily routinely obtained at all institutions. So key here, again, is high-resolution axial and coronal oblique T2 weighted images, and especially diffusion weighted images in the post-chemoradiation setting. Again, the protocol is available on the SABI member protocol website. So a number of findings that we're going to go through, we'll go through these one by one. So the first thing you want to do is, using T2 weighted images, assess the degree of viable tumor versus fibrosis. So how do we do this? So let me show you this case here. And if I told you this patient had prior radiation, you may not be entirely sure how much of this was tumor versus scarring. Now let's pull up the pre-chemoradiation imaging on the same patient, same level. So you can see large semiannular tumor here along the right side of the rectum. If you look on the post-CRT closely, it's this sort of crescentic dark signal intensity on T2 area, this scar that is now much smaller compared to the pre-CRT imaging. So it's really important to compare with the pre-CRT imaging in order to assess what's going on the post-chemoradiation imaging. So in general, viable tumor will be intermediate signal intensity on T2. So this is a tumor that is largely unchanged after chemoradiation. This patient came to us from the outside hospital, had been treated with chemoradiation. This is a large amount of mass-like intermediate signal intensity within the wall. This is residual viable tumor. In contrast, again, to this case that I showed you, which has shrunk from this large tumor and is now predominantly dark on T2-weighted images. This is fibrosis. So viable tumor, intermediate signal intensity, just like the primary tumor would be, and fibrosis is low signal intensity on T2-weighted images. How about this case here? So this is a semi-annular tumor on the pre-CRT. On the post-CRT, there's some low signal intensity in the periphery, but there's maintained intermediate signal intensity. This patient has mixed response. I love this case. This is from the literature. This is the best. I have some cases from our institution, but this is the best way to illustrate the example. So if I showed you this patient, this case, post-chemoradiation, and asked you, what do you think about tumor versus fibrosis? Well, you may look at this area posteriorly here and say, well, there's a large amount of intermediate signal intensity, and this is residual viable tumor. Well, now let me show you the pre-chemoradiation imaging. Posteriorly here, this is just normal mucosa, all right? The tumor is all anterior on the pre-chemoradiation imaging, which is now largely fibrotic and very, very dark on T2 and much smaller. So this actually is very good response. So this is what we call a pseudomass on the post-chemoradiation imaging. So for this reason, it's really important to always evaluate this in context of the initial pre-chemoradiation imaging. So to summarize this point, viable tumor is intermediate signal intensity on T2-weighted images, but always interpret these images in context of the pre-chemoradiation imaging because you don't want to end up calling a pseudomass a viable tumor. A brief slide about mucinous rectal cancer. This is important because these tumors have poor prognosis. They are high signal intensity on T2-weighted images. So if you have a mucinous tumor pre-CRT, this already bodes a poor response. But now let's see the patterns of response after chemoradiation. So you can have a non-mucinous tumor that has intermediate signal intensity on T2. If that undergoes either cellular or acellular mucinous change, that is actually a good thing. These patients have low rate of local recurrence, but they do have higher rate of distant recurrence than patients that respond without mucinous change. You may have a mucinous tumor, a cellular mucinous tumor pre-chemoradiation that now is acellular, and that's a good response. That's non-viable. So cellular mucin is bright on T2 but is heterogeneous and has some intermediate signal intensity. Acellular mucin is non-viable tissue, and this is very bright, homogeneous, featureless on T2-weighted images. If you have a cellular mucinous tumor without response, that is a poor prognosis and increased risk not only for distant but also local recurrence. So here's an example here, annular tumor that's bright on T2. This is a mucinous tumor, post-radiation, largely maintained high signal intensity. This is no response pretty much. So this patient did not do well. They ended up going to hospice shortly thereafter. This is from the literature, a large mucinous tumor here. You can see the areas of high signal intensity on T2. On the post-CRT, you see there's a large amount of more homogeneous, bright signal intensity, featureless, non-cellular or acellular mucin, which is the portion that has responded, and there's some areas of maintained tumoral signal as well. So this is partial response in mucinous tumor. Just one slide about this new sign I heard about at RSNA last year. This was presented at RSNA last year, and this paper just published online in European Radiology. It's called the split scar sign on the T2-weighted images. Just briefly, basically what they're saying is on post-chemoradiation T2-weighted images, if you have a dark line along the inner margin of the tumor and along the outer margin of the tumor with very homogeneous intermediate signal intensity centrally or very bright signal intensity centrally without disruption of the inner or outer margins, this is a good sign. This is what they call the split scar sign, and this they showed had association of, it was 97% specific for complete response compared to so they use sustained complete response, clinical and imaging-based and pathologic-based for their reference standard. So this is just the first paper with 67 patients. They've just defined this sign, and we are not clinically using this yet, but I think it deems mentioning here, and more studies really need to be done about this, but just so you're aware, I wanted to put a slide in here. All right, so moving on from T2-weighted images, how about diffusion-weighted imaging to assess viable tumor versus fibrosis? So a multi-center trial here showed improved detection of complete response when you use diffusion-weighted images in conjunction with T2 compared to T2 alone. Here's some data from that study, 3 readers, and you can see that the area under the curve for T2 and diffusion-weighted images was higher in 2 out of the 3 readers compared to just the T2-weighted images. The sensitivity for detection of complete response was increased by 16 to 52% for the 3 readers. Two patients from that paper. The top row is patient A, bottom row is patient B. Large bulky tumor along the right side, polypoid tumor here becomes fibrotic post-chemoradiation. Semi-annular tumor here also becomes fibrotic post-chemoradiation. But if you look at the diffusion images, the top row, there is an area of restricted diffusion. This is viable tumor, while the bottom row does not have any focal area of restricted diffusion. This is fibrosis. So really diffusion can help be a problem solver in this setting. Here's an example from our database. Large tumor, intermediate signal intensity on T2, and you can see areas of restricted diffusion within the tumor. Also this tumoral nodule here, T3 disease with restricted diffusion. On the post-chemo radiation, you see that this is now dark on T2, both these areas, and they have lost their signal intensity on diffusion. So these are areas of good response. How about this area here? The diffusion nicely shows maintained area of high signal intensity on the high B value, which corresponds to areas of intermediate signal intensity. This is residual viable tumor. So diffusion kind of highlights that a little bit better than the T2-weighted images. All right. So we've talked about differentiating viable tumor from fibrosis. Now we want to give the T stage of the residual tumor and give the extramural extent. So here's that tumor with a large amount of viable residual tissue. We draw where the muscularis propria would be. This is extending past the muscularis propria. This is a T3 tumor. And then we measured the extent outside the muscularis propria, which gives you the degree of or extramural invasion, and you can substage the T3 stage. And this is important because any tumors after chemoradiation that are T3A or below, meaning 1 millimeter or less extension outside the muscularis propria, have a much higher 5-year survival and disease-free survival and much lower local recurrence than the T3B or higher tumors. All right, so we talked about viable tumor, the T stage, we gave them the extramural extent. Now we want to talk about what's called the actual response to treatment. We give a MR tumor response grade, or the TRG. And this, again, it's very important, vital to compare with the pre-CRT imaging in order to give a tumor response grade. This is also one of the independent predictors of patient outcome. So how do we do this? So there's this five-grade scale here. 5 is no response, maintain intermediate signal intensity, same as the original pre-chemoradiation tumor. 4 is slight response, 3 is moderate response, more than 50%, 2 is good response, mainly fibrosis, and 1 basically is where there's not any evidence of ever even treated tumor. So this is important because MRTRG 4 and 5, pretty low survival, 5-year survival compared to 72% for MRTRG 1, 2, or 3. And so let's go through some examples. So here's a patient, pre-chemoradiation, large polypoid tumor, post-chemoradiation. All you have left is this little small crescentic scar. This is an MRTRG1. This patient came to us from the outside. I don't have the pre-chemoradiation imaging, but on the post, there's this very dense, dark scar on T2-weighted images. We call it a TRG2, and on path, there was no residual tumor. This semi-annular tumor along the posterior wall of the rectum, you can see it's a pretty large tumor here, and on this particular area here, it's now much smaller, more than 50%, definitely more than 50% fibrosis, maybe some residual intermediate signal intensity areas. We call it an MRTRG2, and biopsy showed no residual viable tumor, biopsy of this scar. This patient that I showed you earlier, semi-annular tumor on the initial pre-staging CRT. On the post-CRT, there's still maintained intermediate signal intensity while there's some fibrosis peripherally. This was MRTRG3, and the biopsy of this scar showed small amount of residual viable tumor. All right, so we talked about viable tumor, T-stage, we gave the MRTRG, and now we talk about the CRM status, because this is also an independent predictor of patient outcomes, and then we'll talk about lymphovascular invasion and nodal status. So this patient here, large amount of residual viable tumor. You can see it well on the diffusion-weighted images. It's involving the mesorectal fascia, so the positive CRM. Here, it's actually invading the prostate, and you can see that on T2, and it's confirmed on diffusion-weighted images. This is a stage T4 because of involvement of adjacent structures, and on the coronal images, actually, there's lymphovascular invasion. You can see that there is a contiguous tumor signal extending into the vessels. Notice that there's maintained tumor signal, intermediate signal intensity, largely maintained on T2. This is an MR-TRG 4 or 5, really doesn't matter. Point is, this is predominantly residual viable tumor, and patient, unfortunately, would do poorly. All right, so once we've talked about the tumor itself, then we also can talk about the lymph node status. So chemoradiation tends to decrease the size of both benign and malignant lymph nodes, and typically this change follows the pattern of change in the primary tumor itself. Again, just like on pre-chemoradiation imaging, you want to talk about malignant morphologic criteria, which include irregular margins of the lymph node, internal heterogeneous signal intensity, and a round shape. MRI has decent accuracy for predicting lymph node disease or demonstrating lymph node disease after chemoradiation. Patients that have positive lymph nodes on post-chemoradiation MRI have a lower disease-free survival than patients that don't. So here's some examples from the literature. A lymph node in the periphery here that completely disappears, and additional smaller nodes that are quite gone as well. This patient here that develops a high T2 signal in the tumor consistent with mucinous change in this particular lymph node, and then this patient here that has an irregular lymph node that maintains its heterogeneous signal intensity and had residual viable tumor in this particular lymph node upon resection. So important to report change in lymph node status and appearance as well. Last thing here is the reporting template. So this particular, the SGAR guidelines provided this template specifically for restaging after neoadjuvant chemoradiation. They specifically talk about the tumor mass, giving the stage of the tumor after radiation, distance of the residual viable tumor from the anorectal junction, the length of the tumor, whether or not there is any sphincter involvement. Sorry about that. If the mesorectal fascia or peritoneum are involved, and predicting the CRM status based on that. Talk about lymph nodes and tumor deposits, and then the extramural vascular invasion. This is in your handout. And this last case I'm going to show you because it's a great segue to Katrina's part of the talk. It's a patient that was undergoing watch and wait but recurred. So this is a patient that I showed you earlier, had a good response. This scar was biopsied, had no residual viable tumor. So they got a 3-month follow-up MRI, no residual viable tumor. We called it again MR-TRG2. They followed the CEA. CEA started rising, and they got a PET about 8 months later that showed a mass-like abnormality with uptake of FDG, and then they got the MR, which confirmed the recurrence. It looks very much like the original tumor. So with that, the take-home point from my talk, rectal cancer management consists of resection plus or minus CRT, or in certain cases can involve imaging surveillance and non-operative management. MRI is vital for assessing response after chemoradiation. Use T2 weighted images and diffusion to differentiate viable tumor versus fibrosis. You really must compare to the pre-CRT images. If that's one thing you take away from my talk, you always compare to the pre-CRT images when you're interpreting these scans, and then you report location, size, MR-TRG stage, the T stage, the degree of extramural extent, CRM status, if not, whether or not there's lymphovascular invasion, and also the nodal stage. Thank you very much for your attention.
Okay, well, now that you guys all know how treated disease looks, I'm going to be talking about what it looks like when disease recurs. Before I begin, I want to thank some of my colleagues who helped me out with cases for this talk, and I unfortunately have no disclosures. So I've broken it down into 3 parts. I'm going to start off by talking about which patients are more likely to recur, what recurrence looks like, and lastly, how we manage these patients. So the good news is recurrence is actually becoming a lot less frequent. As we've gotten better at treating these patients, as they get neoadjuvant therapy and multidisciplinary management, recurrence rates have decreased precipitously in the past couple of decades, going from over 30% to less than 10%. And usually when these patients recur, it's within 2 to 3 years of their surgery. Unfortunately, about half of them will have metastatic disease at time of presentation, but it's still important to identify these patients because there's very different survival outcomes depending on if they're treated. If they're untreated, their median survival is less than a year. Even with palliative treatment, it goes up to 5% at 5 years. And if they receive appropriate surgery and neoadjuvant therapy, it actually goes up to about a 35% 5-year survival. Again, not great, but certainly a lot better than 1 year. When these patients present, they'll present with things like changes in bowel habits, rectal bleeding, pain, but in about a third of these patients, the recurrence is actually going to be asymptomatic. what makes it harder is these are very complicated patients to begin with. Many of them do have chronic pelvic pain because they've had extensive surgery. They have fistulas, discharge, masses, non-healing wounds, and all of these things can be very confounding to the diagnosis of recurrent disease. So when I think about recurrence, I try to think about the things that will place the patient at increased risk of recurrence, and I like separating them into two categories. You have the things that are related to the tumor itself, and then the things that are related to what we actually do to the patient. So if we want to know things in the tumor that are going to impact recurrence, you could look at the tumor location. So tumors that are lower or more anterior are less likely to recur. You want to look at tumor grade, of course, with higher grade being more inclined to recur, the presence of extramural vascular invasion or lymphovascular invasion, and the presence of adenopathy. But then we could also look at what we do to the patient. So positive margins, very big risk factor for recurrence. The surgery type does matter. Patients with APRs are more inclined to recur than those who have LARs. Things like intraoperative tumor perforation or postoperative anastomotic leakage, and also the surgeon caseload. Surgeons who do less than 10 to 12 cases have higher recurrence rates than those who don't. So a lot of these are getting triaged to multidisciplinary centers for more appropriate management. But if you can't remember all that, because there are a lot of things on that slide, you really only have to focus on three things: the margins, the tumor stage, and whether or not they get neoadjuvant therapy. So if you look at the margins of the tumor stage, patients who had T1 and T2 disease in a positive margin had a 12% recurrence. Those who had T3 and T4, 25% recurrence. You could see that in patients who got neoadjuvant therapy, they had half the recurrence rate of those who only got surgery alone in the appropriate patient population. So if you forget all that, you always want to know about your margins, your tumor stage, and what sort of therapy the patient had prior to their surgery. So what role does imaging play in these patients? We got a lot of modalities at our disposal. Which ones should we be using? Keep in mind that in addition to any imaging that we're doing, these patients are getting colonoscopies and they're also getting CEAs. So it's not the only way these patients are being surveilled. For those patients who've had a transmesorectal excision, be an LAR, APR, CT is really going to be your workhorse of surveillance. They usually get a baseline study following their surgery. It's great for detecting metastatic disease, and it's actually pretty sensitive for local recurrence. Your PET-CT is going to be more of a problem-solving tool than your routine surveillance because of the high number of false positives, and it does have limited detection of smaller lesions. Your MR plays a role in those patients who've had transanal excisions. So usually for those patients, they'll either get sigmoidoscopy or MRI every 6 months for a period of 2 years, rather than getting a CT since they have a much lower risk of metastatic disease. You could also use MRI as a great problem-solving tool in those patients who have had transmesorectal excisions. And as Gaurav mentioned, it plays a role in watchful waiting in those patients who've had a complete response to therapy. So those are your imaging modalities that you have to work with. So now that we know how to image these patients and who's going to recur, what does recurrence actually look like? So there's different patterns of recurrence, and it's helpful to kind of break it down into categories of axial, anterior, posterior, lateral, and remote, which is going to be your metastatic disease. Obviously, you can combine these categories. It doesn't only occur in one compartment, but this is generally how it's categorized. So your axial recurrence is going to be along the expected course of the rectum, or if the rectum is resected, in the perineum. So your patients have had an LAR. This most often occurs at the anastomosis. Your patients post-APR in the perineum. And for your TAE patients, this is usually a local recurrence. So if you have an anastomotic recurrence, it could be intraluminal, which is actually usually very well seen with endoscopy, or mixed, or it can be extraluminal. And here's an example of that perineal recurrence that you'll see in your patients post-APR. And here's an example of a recurrence at the superior margin of the rectal stump. Again, these usually occur near the suture lines, and you could actually see the suture right there. So the anterior recurrence is invasion of the bladder or the reproductive organs. So here we have a case where you have tumor extending anteriorly to contact the posterior wall of the vagina and the posterior cervix. The men who involve, obviously, the prostate and seminal vesicles. And the reason why it's important to differentiate these is axial and anterior recurrences usually have better surgical outcomes. These are usually easier to resect, so you do want to identify these. Your posterior recurrence are those that involve the presacral fascia or the sacrum or coccyx. So here we have a case of a fistulous collection that actually had recurrent tumor within it, invading the presacral space. And then your lateral recurrence is going to occur along either the bony pelvic sidewall or the pelvic sidewall structures, and here's an example from the literature of that. And of course, then you have your remote disease, and keep in mind, again, half of your patients will present with metastatic disease at time of recurrence. So you always, always, always want to look for the metastatic disease. So here we have a patient, they're 18 months post-treatment with a rising CEA, and if you look closely, this was that patient, they had a known presacral fistula, but over time we see increasing density within that fistula. They received an MRI, which showed, again, soft tissue in that, as well as a PET-CT, because, have both modalities at our disposal, and this was a biopsy-proven recurrence. So it can be subtle on CT, but you can distinguish it. Here's another case of a patient who was 26 months post-LAR. You can see on this scan, there's no adenopathy. On their follow-up scan, they have a new retroperitoneal lymph node that's obviously pretty abnormal. And if you look carefully at the anastomotic margin, you can see there's increasing soft tissue density at the anastomotic margin. So they had metastatic disease as well as a local recurrence. Here was a patient 2 years post-LAR with new lung nodule. They got a PET-CT to evaluate the lung nodule. At the same time, they saw uptake at in the rectum, and this was a local recurrence as well as metastatic disease. So if we're looking at these areas on MR, it's important to try to differentiate fibrosis from tumor. And you kind of use the same principles that Gaurav talked about in our last session, that you want to look for T2 signal, you want to look at diffusion-weighted imaging. In general, with fibrosis, you will see decreasing T2 signal over time, angular margins, and it really shouldn't enhance quite as much. Whereas your tumor will typically have rounder borders. You can see here a recurrent tumor, although it's T2 intermediate, does have very round borders. It can also show more avid enhancement. So here we see an area of focal enhancement, whereas in fibrosis, it should be more smooth. This was recurrence within the wall and had focally restricted diffusion. That was not the same all around the tumor, so even though it was intramural, it was focally restricted diffusion. But keep in mind, there can be considerable overlap in these imaging features, which make it a little bit confounding. So here are a couple of cases. This is a 55-year-old male, post-LAR with a rising CEA. Not much showing up on T2-weighted imaging, but on the diffusion-weighted imaging, you could see there's an area of focal restricted diffusion, and this corresponded to our biopsy-proven recurrence. So it's T2 and diffusion-weighted imaging, and in some cases, enhancement that help you make the decision. This was another case. You can see there's extensive fibrosis, very T2 hypointense signal on this MRI, and there's maybe a little area bulging into here. What we see is there's still that T2 hyperintense fibrosis, but on their follow-up scan, we see an area of growing T2 signal, and this was an extraluminal disease and a biopsy-proven recurrence. So that enlarging T2 signal is one of those things that you want to look for. And again, it demonstrated markedly restricted diffusion. That certainly helped it pop out. This was an interesting case because this was a 55-year-old male post-transanal excision. We didn't have an MR prior to his transanal excision, and this was what we got, and it actually looked the same over 2 scans because, well, we actually saw him 2 scans in. But when we looked at it, we saw this focal area of restricted diffusion in here that we were concerned about, and maybe a little bit of enhancement. So then the surgeons biopsied. They actually weren't that impressed with it. They thought maybe it was a polyp, and because of its more suspicious appearance and that focal area of restricted diffusion, we recommended rebiopsying, and sure enough, this was invasive adenocarcinoma. So even if the pathology is sort of going against what you initially thought, don't be afraid to tell them to rebiopsy because these are aggressive disease and portions of it may be more aggressive than others. So be confident. Lastly, I want to talk a little bit about how these patients are managed. So if there is a suspected recurrence, ideally you want to get a tissue diagnosis if possible. These patients should then be assessed via pelvic MR to assess if they are potentially resectable. They should have either a CT or a PET-CT to look for metastases or occult metastases. If this is not possible, at some institutions, they actually will do laparoscopy to evaluate for metastatic disease. But what I want you to notice is regardless of whether or not diagnosis is confirmed, these patients still should be presented at a multidisciplinary discussion. If they have likely disease, you want to assess, are they resectable? Should they be getting neoadjuvant therapy or adjuvant therapy? If the diagnosis is uncertain, you want to establish a firm plan of follow-up to either repeat imaging, repeat the CEA, or in some cases, repeat the biopsy. So you really do want input from everybody on how these patients get managed. Because the ideal goal in a recurrent patient is to get an R0 resection. So resectability means you get an R0 resection with acceptable postoperative morbidity and mortality. You don't want to achieve an R0 resection at the total expense of the patient's quality of life. But you really, what you want to ideally have no disease left. What you want to avoid is the R2 disease, because if you have macroscopically positive resections, these have higher complication rates and absolutely no survival improvement. So this is ideal. This is not ideal, but better. But that R2 resection is really doing absolutely no benefit to your patient. So how do you determine who's resectable? I want to stress that these are all relative contraindications. They will vary depending on the surgeon and on the institution. But these are the things that you want to look for and specifically address in your report. So unresectable extrapelvic disease or sacral involvement. When we talk about sacral involvement, it's really that involvement at the S1, S2 level or involvement of those sacral nerve roots that will oftentimes push patients into that non-resectable status. When I talk about metastatic disease, surgeons will actually be pretty darn aggressive with resecting any sites of metastases, because again, for these patients, getting rid of that disease is really going to improve their survival considerably. So here was a patient, they had an implant in their abdominal wall that they thought was possibly a port site implant, as well as local recurrence, and this patient was resected. Similarly, a patient who had lung cancer met, they're very inclined to resect local lung metastases. So it's really important to detail all the sites of suspected metastatic disease because it does not necessarily preclude resection. Ureteral encasement is considered a relative contraindication, especially if it's bilateral, but unilateral they still will consider resecting, although again, depends on other factors, as well as iliac vessel encasement. So these are all the things you want to make sure to explicitly mention and describe in your report because they will alter the management of the patient. So in summary, it's important to realize that even though rectal cancer rates are low, they have very high mortality if they're not treated. About half of our patients will present with metastatic disease, so you always want to look for that local recurrence as well as synchronous mets. You want to thoroughly describe your local recurrence and any possible sites of metastatic disease because this will aid in planning your resectability. And really, multidisciplinary management of these patients is mandatory for appropriate management. So, thank you.